So our final speaker is Dr. Ann Andermann, who is the founding director of the CLEAR collaboration. Dr. Andermann is a family doctor, a public health physician. And just to go back to the CLEAR collaboration, I'm jumping ahead. The aim is to help frontline health workers address the underlying social causes of poor health through a combination of direct patient care, referral, and advocacy for larger social change. Dr. Andermann has previously worked at the World Health Organization, where she was a main contributing author of the World Health Report in 2008. Dr. Andermann has been a visiting lecturer at major universities in the US, Brazil, Germany, and the UK. Currently, she's a public health physician at the Cree Board of Health and Social Services of James Bay, Northern Quebec, chair of the Community-Oriented Primary Care Committee at St. Mary's Hospital, and the focal point at the McGill Faculty of Medicine, responsible for incorporating greater emphasis on the social determinants of health and a population health approach with their new medical school curriculum. Dr. Andermann was recently awarded the Canadian Rising Stars in Global Health Award from the Grand Challenges Canada, and her new book is entitled Evidence for Health: From Patient Choice to Global Policy, and is now available from Cambridge University Press, and the website link to that is on your website if you would like to look at that further. So thank you, and welcome, Dr. Andermann.
Thank you very much. It's a real pleasure to be here with so many like-minded people on the panel and also in the room, and I look forward to speaking with you at length during this meeting. So this session, I hope you're not all too tired after many speakers, but I hope I'll keep it exciting. This session was looking at public policies. And as we know, healthy public policies that protect and promote the health of vulnerable patients and populations are critical. But what happens when these policies are slow to emerge? Or what happens when these policies actually then become retrograde, as we've heard? So you can't ever take things for granted. Things can always go backwards. And also, sometimes policies are implemented and you think that these will be good policies, but they're slow to trickle down, and they don't really make change on the ground where you need them. And sometimes they even have perverse effects. So what I wanted to talk to you today is what can be done at the grassroots level, because you need the top down, but as we know, we also need the bottom up. And there are things that can be done to better support our patients, to try to promote this wider social change. And another sort of phrase that you often hear in Indigenous health is not for me without me. And also Ritika very eloquently said, amplifying the voices of people not traditionally heard. And as health workers, we're really in such a good position to do that kind of work, a position of privilege, being invited into people's private spaces and being able to sort of bring these messages out and help them be heard. So I hope that this presentation can help make some voices heard, and that's a lot of the research that we do. So as mentioned, I'm a physician, family doctor and public health. Actually, I met Dr. Shaw when I was interviewing for residency here in Toronto in 2002, and since then I've done my career mostly out of Montreal and McGill. And so, of course, I don't have to tell the audience here that the health of the individual, like this little baby, very much depends on the home environment and the health of their community. So you cannot take your patient's health out of this context and in a vacuum. And of course, while most health workers focus a lot on diagnosis and treatment, we also know that there's a whole spectrum of strategies, a whole continuum, different levels of prevention and also health promotion. The Ottawa Charter, of course, healthy public policies and supportive environments for health is from the Ottawa Charter from 1986. We know that these are the right pathways, and I would even pull out further the action on the social determinants. And while this is sort of a newer movement, different strategies, including health in all policies and intersectoral action that goes beyond the health sector, are being recognized, and we're really just learning how to do this in practice. There's a lot of high-level documents that are asking the question, what is it that health workers can do in all of this? If we need to change things beyond the health sector to be able to promote and protect the health of vulnerable populations, then what role really is there for health workers? And I would argue that there still is a very important role. So that was really the impetus for this, busy health workers, what concretely can they do? And this is what my medical students ask me. I teach now 225 medical and dental students their first month of medical school called Block A, Improving Health from Molecules to Global Health. And I did get some of these, lefty comments as well. Students who say, bring on the cadaver, and why are we learning about this? And they want to have the concrete actions, just tell me exactly what I can do. And so about 5 years ago, we started something called the Clear Collaboration to really try to distill and do research on what really works on the front lines, what really can health workers do at different levels. And you're welcome to visit our website, and the materials are available now for download. Basically, over the course of this time, with many iterations, we've developed something called the Clear Toolkit. And I think there's several different kinds of toolkits emerging across Canada. I'm aware of different researchers. I think that they're very complementary in nature, so this doesn't replace the importance or the value of other ones. And it's nice to see that there are multiple things springing up. So it's a decision aid to help people take action. And the main tenets are that frontline health workers can make a difference by, of course, treating the immediate health problems that people present with, but also asking about their underlying social problems, referring to different local social support resources, and advocating for more supportive environments. This has been a long development process, and we're still undergoing lots of different testing in different contexts. Our 4 partner countries that we started this global health research project were Brazil, Bangladesh, Niger, and Pakistan. And we've also done local global research. The community of Côte des Neiges, where St. Mary's Hospital is located, has a highly diverse population with over 60 or 70 languages spoken, and very many immigrants and refugees living in that community. So we've done research there, and we've also done research in Aboriginal communities in Northern Ontario and Quebec. We're always interested in understanding how can this be applied to different contexts, and how can we learn from people who already do this kind of thing. How do they do it? What works for them? And how can we get everyone to start doing this kind of thing in their practice? So we really want to learn from what people are already doing, because there are many people who are already local activists in some sense, supporting patients and promoting larger change, and we're trying to make an actual academic study of this to understand better, rather than there's already a lot of commentary pieces and so forth in the literature, but not as much research. So from some of the qualitative interviews that we've done, and I won't read every single quote and so forth, but we were starting to ask, first of all, what kinds of vulnerability exists and what are some of the causes of this vulnerability across all these different contexts. And of course, there's many of the same themes that came out, and I would agree also that trauma is certainly a very big theme, stemming from things like poverty, family instability, lack of child care, abusive home situations, unsafe neighborhoods. And this tends to sort of compound itself, leading to different downward spiral of additional exploitation, abuse, stress, marginalization, and maladaptive coping strategies. One of the children said, "People hate us. Once some garbage fell down from the cart and the officials beat me black and blue." And I think that this is a recurring theme, that people who are vulnerable, who should be cared for, are actually so marginalized that they become the object of the problems and sort of set aside, rather than being cared for by people who are supposed to be caring for them, like, policemen and so forth. And just time and again, we hear stories and stories of abuse and trauma. So what can health workers do? And there will be an article that I was pleased was recently accepted by the Canadian Medical Association Journal, where we're drawing together the literature. Most of this literature is from high-income countries, focusing on low-resource settings like inner cities and so forth. But there is a small amount of literature from low and middle-income countries as well that complements that. But really, things are emerging at 3 different levels. People being or health workers rather, being able to support their patients at the patient level, but also things that they can do at the practice level to make a more safe environment that's more accessible to populations in need, and also things that can be done at the community level, many of the things that we've heard in the sessions today about how to mobilize this larger policy change. So just some quotes, because what we find in the literature very much reflects also what has come out in our qualitative research in low and middle income countries and also locally. So what can we do? Being caring, listening respectfully, and avoiding these social prejudices that are prevalent, and health workers are part of the larger society and they are necessarily also exposed to these things. So this example, the nurses covered their noses while they bandaged us. They looked at us as if we were some different species. So obviously this is not a sort of a fuzzy caring experience when you're feeling unwell. These are definitely things that we as health workers can change to make it a better experience for people in vulnerability. Asking about the underlying social challenges. Often people don't want to open up a Pandora's box, but we have done some research. My previous master's student from Pakistan, in her project, she showed that the health workers who knew how to ask in a sensitive and caring way about people's social vulnerability were more likely to report having helped people with these issues. And so that is like the first door to open. It doesn't mean you have to solve every single problem, but if you don't even know about it, you might prescribe a medicine that of course they can't afford, or you might be missing out on important problem of violence in the home, which can go across the socioeconomic strata. It could be in a wealthy family, in a poor family, but if you don't ask about these things, you wouldn't know. And of course, referring patients to sources of social support. It always is sort of a bit of a trigger when residents say, yeah, I'm just going to refer to the social worker, but I mean, you can't. First of all, sometimes it takes months for them to see the social worker, and we have this whole, Montreal itself has like 3,000 community organizations, but it's a little overwhelming. But all you need to know is make a little bridge. So we introduce them at the beginning of each year. We do this annual community walk to about 5 organizations. There's the local food bank, there's the housing rights organization, there's something called Project Genesis that helps them fill out those complicated bureaucratic forms till they get their benefits to which they're entitled. So once you have the door open, then all of these community groups know all the others, and they are able to refer amongst themselves as well. So making those kinds of bridges. And you might be surprised, but so mapping out these local referral services, again, just a few key ones, and providing outreach to those most in need. I don't know if I skipped a slide. I don't know if it's possible to go back. Maybe not. Okay, so at the practice level, before you would even sort of implement something like this, it's helpful to know like what are those few key resources that you could train other people locally to use, and also to be able to provide outreach insofar as possible to people who are out in the community but don't even make it across the threshold of the clinic. And then finally, at the community level, a lot of what we have seen, engaging communities and community leaders, collecting some data and narratives on what's going on. Some of our residents have a R1 scholarly research project, and for the last 3 years, they've been doing research on homelessness in Côte-des-Neiges. And we found that in our own backyard, there's forced marriages, there's prostitution, there's, all of these, and not only is there what we would call like, classical homelessness with people living on the street, but also there's a huge problem of hidden homelessness and elderly homelessness. And so how little we know the own community that we serve, especially in urban centers, and how much this kind of just research involving local community groups and local vulnerable people within our local communities to really shed light on what's going on, because our eyes are just closed to so much of this. So with that, then you're equipped to sort of advocate for community development, perhaps get involved in local community planning. I'm now sitting on a community-led coalition on the topic of homelessness that includes the food bank. It also includes the local police. It includes the local health organization. It includes the local municipal officials, and all of these people are now together, having a reflection day on what more can we do, and we contribute our little piece to the puzzle by making some of these voices heard in terms of what are some of the issues that people are struggling with. And sometimes, really small things can make a big difference, and I always, interested by this quote, this 13-year-old newspaper vendor in some train station in Bangladesh who said, the health workers can protect us from child trafficking. Who knew, right? Sometimes people come to us and offer to work in hotels, but we don't know if this is a good person or he's involved in trafficking, and only the health worker can tell us about that person. We can get suggestions from health workers about these kinds of offers. People are not always aware of what's good and bad, and to have someone that they can really trust and rely on is a very important thing. So while, of course, intersectoral approaches that go beyond the health sector and health in all policies is critical, I believe that health workers still have an important role to play in addressing the social determinants. First of all, avoiding being part of the problem, and that's this whole notion of making safe spaces where patients can come for care and providing the outreach and so forth. Better supporting vulnerable patients in many different ways and being cognizant of the different resources, that we're not alone in doing this and we don't have to carry, a whole burden and take 45-minute consultations, but at least if we know what's out there and over time we can provide support. And finally, a lot of what this session has been about, which is also catalyzing action, joining partnerships, and mobilizing this kind of larger change to create these supportive environments for health. So this toolkit that we have is now translated into over 10 languages, and there's also a trainer's manual to help adapt it to each local context. Even within Montreal, we have it adapted for the Côte-des-Neiges context, but we have another physician in Park Extension who's interested in using it, and I think we would probably have to readapt it somewhat so that it's really tailored to the type of immigrant population there and the different local resources that they have there. It doesn't take more than, a little half day or a couple of hours where you get some key people together to discuss how to adapt it, but it's something that should be done so that it's really applicable locally. So if anyone is interested in piloting this concept in your local area, please feel free to contact me. And I'd like to thank our funders for their support, and here's a couple other resources that you would be welcome to look at. So thank you very much for your attention.
Thank you, Dr. Andermann, and thank you to all of our esteemed panelists for their thoughtful and inspired and inspiring talks this morning. Unfortunately, we're not going to have time for questions just because we are running a bit late. However, I would encourage all of you to hold on to all of your comments and enthusiasm and use the upcoming sessions and workshops and the rest of the weekend to further explore and ask those questions, because many of the themes that have been brought up will be discussed further at the upcoming activities. Just to conclude our panel, I wanted to provide a couple of minutes if anybody wanted to make any comments, concluding comments or remarks on each other's presentations, or any kinds of final words or thoughts to take home for people. Anybody? All talked out. Dr. Shaw?
As an elder, I'm allowed to say last word. Anyhow, I think you had a lot of, this presentation gave you a lot of ideas and so forth. And try to reflect and see where you can make a difference You don't have to go all the way, but there are, as I pointed out, there are steps at different levels, and that's where if you think that's all the energy or resources you have, put it there, because as Gandhi said, and it was a very interesting statement from him, silence is violence. In some areas where we don't speak up, he equated it with violence. Same thing I would say, inaction in this area is violence. Thank you.
Thank you.